Okay, good afternoon everyone, here and at home or wherever you are watching today's Grand Round. So with great pleasure we've got Associate Professor Adel Ekladious, who is a Senior Staff Specialist in General Medicine and the Acute Medical Unit. Has a very illustrious career of spanning multiple states and multiple countries. You can see the qualifications there attest to his expertise in multiple areas. So we're very lucky to have him. He'll be presenting today on a very interesting case and a diagnostic dilemma of acute dyspnea. So an unusual presentation of a common presentation. Okay, without further ado, Adel, come up to the podium. That's your microphone.
Thank you very much, Ashwin, and all attendees. I have 35 minutes to talk, and I will try to behave in the 35 minutes. As Ashwan mentioned, the title was a common manifestation of uncommon disease, but I will work hard to convince you at the end of the talk that it is a common manifestation of a common disease, which all of us will miss the diagnosis in a timely manner. So, this is the forwards. Okay, so I'll talk about a case, but I'll be very quick so we can talk about the discussion. The case is just a lady, 46, female, with a history of drug injection and alcohol, and she contracted Hep C. And she came with sudden onset of dyspnea at rest, which usually marked dyspnea. And she had a right-sided pleuritic chest pain for the last 2 days. She is on thiamine and multivitamin for the chronic alcohol use. This is the observation, and you can see nothing here unusual. Respiratory examination showed signs consistent with right pleural effusion, decreased air entry and decreased vocal resonance with low midline shift, but if there is signs of a chronic liver disease. The rest of the physical cardiovascular examination was unremarkable, especially there is no loud P2, and there is no signs of heart failure. The gastro examination also signs of chronic liver disease and probably very mild ascites, which you need to work hard to confirm the ascites clinically. The remaining of the exam was unremarkable, and the slides is not moving anywhere now. Maybe this one, yeah. Okay, and usually you ask for some few blood tests, and from you can see here there is nothing exciting. The inflammatory markers are unremarkable. The potassium is just low, and the alk-phos is 139. Bilirubin is just at the upper limit of normal or mildly elevated. No coagulopathy and probably mild hypercholesterolemia. Brain natriuretic peptide is 175, which probably within normal. This is a chest X-ray, and showed that she had a significant right-sided pleural effusion. And some people will say, yeah, what is the differential diagnosis here? She is not known to have fluid in the lung before, but she has not been diagnosed as cardiac disease before. In the same time, she is not feverish, and it does not look like that she had parapneumonic effusion or pneumonia. And the standard practice is to do a paracentesis to see what is the fluid like, and to apply the light triad to see if this is transudative or exudative. So you will ask for the simple things: the albumin, the protein, the cells, the lactic acid dehydrogenase, and usually people working in respiratory medicine, sure, they will ask for pH to make sure that the patient does not have empyema and the patient is immunosuppressed, and she might not mount signs of inflammation or infection. Of note now, PNP, which I'm struggling to get it in the hospital so far, is an important investigation to be done in the pleural fluid and acetic fluid, and I will convince to you on the end of the talk why. So this patient had the light triad, and this is showed exudative fluid, where the ratio of the albumin between the fluid and serum is less than 0.5, and the ratio of lactic acid dehydrogenase is less than 0.6, and the lactic acid dehydrogenase is less than 200. There is a trick here. You might get high protein and high lactic acid dehydrogenase, or in other words, you might get an oxidative pattern if you apply the light triad in two situations in medicine. If the patient, in two situations of medicine, if the patient on massive doses of diuretic, or if the patient has high immunoglobulin or multiple myeloma. The ECG here does not show any pathognomonic signs of old infarction or left ventricular hypertrophy or conduction block. And then so far you will say this is a transudative pleural effusion. Why and what to do next? You know, the transudative pleural effusion, usually it will not come all of a sudden. Usually you will have a patient have a chronic disease characterized by malabsorption or hypoalbuminemia or nephrotic syndrome, or sometimes heart failure or liver cirrhosis. All these are question mark for the diagnosis. And then you might not be able to get the echo immediately if this patient admitted under general medicine, and you want to know what is the reason of this massive pleural effusion. So probably you might transfer your patient under respiratory. Respiratory will do the paracentesis and say this is transudative. We have nothing to do here. This patient does not have pneumonia or small cell carcinoma or parapneumonic effusion, that's it. Send the patient home. And patient will be readmitted back in general medicine or acute medical assessment unit. If you are lucky and get the patient admitted under cardiology for pleural effusion, and you have to convince somebody in cardiology that you want the echo to be done because you want really to diagnose this lady. She has a chronic liver disease, and you want to exclude cardiac manifestation of chronic liver disease. And if you have an expert cardiologist, he will recognize that there is really something called cirrhotic cardiomyopathy, portopulmonary hypertension, hepatopulmonary syndrome, and last but not least, hepatic hydrothorax. But you have to have a very good advanced trainee to convince him to do the echo to exclude cardiopulmonary disease. Because if you excluded cardiopulmonary disease, what is left is pleural disease. You might need to go and talk back to respiratory. But if you have a background that sometimes there is rare diseases, like, which we call rare diseases, like hepatothorax or hydrothorax, where the fluid in the abdomen will have unidirectional transfer from the abdomen to the thorax due to increased intra or positive intra-abdominal pressure and negative intrapleural pressure. In the presence of what is called diaphragmatic flips, the diaphragm is composed of muscle and membrane in the right side and in the left side. It is less muscular on the right side and more muscular on the left side. And the flips could be just very tiny or ruptured or even gaps in the tendinous part of the diaphragm. And this will allow the fluid in the abdomen to transfer to the pleural space because of the gradient between the positive intra-abdominal pressure and negative intrapleural pressure. How to diagnose this is to get a transudate and patient to have a chronic liver disease with portal hypertension and probably decompensated chronic liver disease causing ascites. You might stop me here and told me that this patient does not have significant ascites. Why the fluid in the chest so massive and there is almost no fluid in the abdomen? And I'll come back to you with this, with a publication in Internal Journal with patients who have no ascites again at all, dry, and has a pleural effusion due to hydrothorax. To confirm the diagnosis, if you are in doubt, you can inject saline labeled with technetium in the abdomen and do the scan after 2 hours, and you will find the dye in the chest. So there is a transfer from the abdomen to the pleura. You might ask me also at the discrepancy between the fluid in the abdomen and the fluid in the chest. Number one, if the efficiency of the pleural system is very high and be able to absorb all the fluid before the absorption in the abdomen, you might find that there is no fluid in the abdomen at all and all the fluid in the chest. And if you are in doubt, you will do the nuclear scan. So as I said to you, this patient has Hep C, and she had been treated before the era of direct antiviral. Although she had sustained remission, but the antiviral might treat the hepatitis C and get a sustained remission, but they will not prevent the ongoing cirrhosis. And this patient had cirrhosis before the era of fibroblast. We need to use the simple test like APRI score. APRI score is a score for the ratio between the AST and the platelets. If it is more than 1.5, it is very consistent with cirrhosis. If it is less than 0.5, it is unlikely to be cirrhosis. The APRI score for this patient was 1.5. The CT of the abdomen here, as you see, shown a cirrhotic liver with a minimal ascites. And as I told you, the fluid is a transudative fluid. To confirm that the fluid in the pleura is hepatothorax, you have to exclude a cardiopulmonary disease and the pleural disease. So you have to do the echo and the CT of the chest to exclude anything on the mediastinum or the parenchyma, and to do an ultrasound for the liver to look for signs of portal hypertension, because this is the main issue here, is the portal hypertension or sustained portal hypertension, which give rise to liver cirrhosis and decompensated liver cirrhosis, and the complication of decompensated liver cirrhosis, which could be ascites or intractable ascites or hepatic encephalopathy or esophageal varices or hepatorenal syndrome, and last but not least, hepatothorax. How the portal hypertension cause all of this? Usually when you have sinusoidal obstruction by the fibrous tissue, increased sinusoidal pressure, this will lead to inflammation and oxidative stress in the splanchnic area and induction of nitric oxide and other prostaglandin. This will lead to dilatation of the splanchnic vessel, which leads to decrease in the effective intravascular volume, which augment the renin, angiotensin, aldosterone, sympathetic vasopressor system, and this will lead to avid sodium and water retention, and this will lead to the ascites. Then the ascites, if you have the fenestration in the membranous portion of the diaphragm, this will lead to the hepatothorax. The definition of hepatothorax is 500 ml in the pleural cavity in the presence of chronic liver disease and portal hypertension, in the absence of cardiopulmonary or pleural disease. So why it is important to diagnose the hepatothorax? Because this is the turning point and the tipping point where the medical care at this point should be multidisciplinary care, which includes the hepatologist, chest physician, and the transplant liver surgeon, and the dietitian. This is number one. And number two, to know how to treat the hepatothorax. And the way to treat hepatothorax is quite different from any pleural effusion. It is ascites in the chest, and you have to treat it like ascites exactly, which means you will start with sodium restriction to less than 2 grams a day, but remember that sodium restriction less than 2 grams a day is difficult. And when you restrict sodium, you also restrict the high caloric food, and you might expose the patient to nutritional deficiency in a vulnerable patient who is cirrhotic and who is already has nutritional deficiency. And then you will start diuretic, and you will start with the spironolactone to counteract the RAS, activated RAS system, and the furosemide. And you start with a dose of 100 spironolactone, furosemide 40, and you can escalate to up to 400 spironolactone and up to 160 furosemide. Some patients will tolerate, some patients will not tolerate and develop hepatorenal syndrome and hypokalemia and postural hypotension and even falls. What you want the patient to lose ½ kilogram a day if he has no peripheral edema, and 1 gram a day if he has a peripheral edema. And you can follow this by measuring the sodium in urine or the spot urine for sodium potassium. If the ratio more than 1, can you keep on the time, tell me, before 5 minutes?
Yeah, another 5 minutes.
Another 5 minutes?
Yes.
Okay, sorry. Okay, it seems that this might need 1 day talk. Okay. Diuretics, and then if diuretics does not work, you have to reduce the portal hypertension by other means. What you need to do in hepatothorax, you need to decrease the formation of acidic fluid, and this is, as I told you, by diuretics. If diuretics did not fail, large volume paracentesis and albumin infusion, and if this did not work also, you will go for TIPS, transjugular intrahepatic portosystemic shunt, which is a shunt between the right hepatic vein and portal vein. Because there is a gradient between the portosystemic gradient is up to 12 or even more to manifest with portal hypertension and manifestation of decompensation. The aim is to decrease the hepatic venous pressure gradient to probably between 10 and 12. This is the therapeutic window. This is the window which open at 10 and close at 12 to prevent any complication of TIPS. And when you implement TIPS for the patient, you are doing this as a bridge for liver transplant, as a definite treatment for the patient. So this is how to reduce the amount of fluid in the abdomen. Another things which not unusually used also is to use the somatostatin analog or teliprazine to constrict the splanchnic vessels and decrease intravascular volume and counteract the renin-angiotensin aldosterone sympathetic system. Then, if this does not work, you need to prevent the transfer from the abdomen to the pleural fluid, and this is to fix the gaps here. And this is probably invasive surgery if the patient has a good performance. You need also to reduce the fluid in the pleural cavity, and this is usually doing by repeated paracentesis or implantation of the intrapleural catheter, and this is usually a catheter to be implanted under the skin. Remember, chest tube is contraindicated in hepatothorax because it increases the hypoalbuminemia in a patient who already hypoalbuminemic and expose the patient to infection in a vulnerable group of patients. Pleurodesis, which will obliterate the visceral and parietal pleura, but it is not a definite treatment. And one thing also which is used, it has been shown that patients with sleep apnea syndrome usually do not develop hepatothorax. Do you know why? Because usually this patient will use CPAP, and CPAP is a positive pressure, and the positive pressure will increase the intrapleural pressure. And when you increase the intrapleural pressure, you will decrease the gradient between the intrapleural pressure and the intra-abdominal pressure. So you can use CPAP. But patients who has encephalopathic cannot tolerate CPAP because they will be at risk of aspiration. The last thing is the liver transplant. And this is the most important thing. Most of the patient, if you get to diagnose the hepatothorax in a timely manner and implement the multidisciplinary team, and the patient will be started at any of the model of treatment I have mentioned as a bridge to liver transplant. Usually they look at a MELD score. MELD score is a model of the severity of chronic liver disease. And recently they added sodium because they recognize that low sodium is also an adverse prognostic factor. Patient who been diagnosed on time and get tips as a bridge to liver transplant and then give a liver transplant, all the RCT studies showed fantastic outcome from the prognostic point of view and mortality point of view. But patients who miss the boat or who was not diagnosed on time, usually they are very high risk, because just to diagnose hepatothorax, this means that at this point the patient is at risk to die in 1 year from all the complication of the increased portal hypertension. So just I want to finish with one slide. This is a patient, this is a publication on May 22. This is a patient who has a chronic liver disease due to Hep C and came with just pleural effusion and no ascites at all. And the pleural effusion and examination of the abdomen and fibroscan confirmed that this patient has portal hypertension, and the pleural effusion confirmed by the nuclear scan and the fluid examination as a hepatothorax. And this patient was treated with liver transplant, and the hepatothorax had been cured. So given that hepatothorax does occur in 5 to 15 of patients with chronic liver disease, and we usually miss the diagnosis because there might be no symptoms at all, except if we take into consideration that a patient with chronic liver disease should be worked up for all the cardiac complication of chronic liver disease. So I might say now, if we take into consideration and investigate for this in a timely manner, I am now able to say that dyspnea as a manifestation of hepatothorax is a very common manifestation of a common disease. I will stop here and happy to answer questions.
All right, thanks Adel. That was a tour de force through hepatic hydrothorax. So we've got a couple of people from gastro who just walked in before at the back there. Hello. Just a specific question to the gastro team here. How often do you see hepatic hydrothorax as a presentation of chronic liver disease in our institution?
We've seen a couple of cases. I've had a couple of patients who looked after
Yes.
at minimal ascites but significant large volume hydrothorax that have gone on to have a TIPS procedure and done quite well following that. So we have seen similar cases to this.
But the question here, do you involve or consider the liver transplant at this point or not? Because this is now the standard practice. The patient who develop hepatothorax, he is at high risk to die.
The cases that we had were patients were not appropriate for liver transplantation, or quite frail and elderly, and they had been assessed in the liver transplant in Sydney. But one of them, I think, they recommended a TIPS procedure as a bridge to transplantation, but they've done well since the TIPS.
Thanks. That's it. Any other questions about the case or about the how to make the diagnosis? Anyone online? Mohammed, have you got the online chat? I guess one question is the nuclear medicine scan that was done. Was that difficult to get where this was done, or was it something that was
very easy? Like the PNP, $20.
The nuclear
The cost of PNP is $20, and the cost of this is not expensive.
You were saying before you're talking BNP in pleural fluid.
It's very good that you mentioned this. Patient, this for the gastro. Patient who have hepatothorax, it is now have been approved and approved and confirmed by FDA that when you check the PNP before the stent or before preemptive stent, you know if this patient, how he will do after the stent, after the TIPS. Because when you do the TIPS in patient who have compensated heart failure, usually you will decompress the portal hypertension, you will increase the cardiac output, you increase the preload, and the patient will decompensate after TIPS. If you do the PNP before TIPS and the PNP is high, you will know that this patient is high risk to have complication after TIPS. And this is now a standard in few gastro units.
We do routinely do an echocardiogram and cardiac assessment prior to TIPS.
No, I think that the difficulty here, this patient could have cirrhotic cardiomyopathy. Cirrhotic cardiomyopathy cannot be diagnosed by an echo. It needs a stress echo because this is due to the depletion of the beta blocker receptors. So you have to exercise the patient. And this patient usually cannot exercise because they are nutritionally deficient. So this is a problem. It is difficult to diagnose cirrhotic cardiomyopathy.
It's hard at the moment to get an echo here, let alone stress echo.
Okay, so.
I noticed that this patient had high blood pressure. How do you manage blood pressure?
Sorry?
The patient has a very high blood pressure, 150/90. How do you manage the blood pressure?
How do I manage for this patient?
But this patient you presented,
Yeah.
blood pressure of 150/90. How
Yeah.
do you manage it?
Yeah, this patient, I
Wanted to just
Sorry?
just to repeat for the online people. So the question is about this particular case had systolic hypertension,
150/90.
150/90, and the question was how was that managed in the context of this liver disease?
Yeah, usually when you have hypertension in the context of chronic liver disease, the ACE and ARB are contraindicated. Usually you will give the non-hydropyridine calcium channel blockers for this patient.
Okay, we've got Professor Pavley at the back. Any comment? You've had vast experience as well in this world, no? Any other comments? I mean, I think from first principles it makes sense, and for me one of the learning points was about the fenestration of the right diaphragm versus the left. It was a bit unusual why you'd get effusions on the right side rather than left.
Yeah.
The learning point for me is that you can get hydrothorax without significant ascites, because I think if you've got gross ascites and you've got fluid in the chest, it's fairly obvious what's going on. But you've taken us through a pretty clear diagnostic paradigm as to how to go through that. The nuclear medicine aspect is quite a neat way of proving it, so it would be just something for us to keep in mind as well. BNP is available now through our, we have it here through our biochemistry lab. It's not as quick, it's not a point of
This is a problem. It is not quick.
It's not a point of care test, but it is Monday to Friday within business hours you can get it as a routine test, and we're working on a case to develop it after hours and on weekends to be a routine test. We do see it as useful in terms of particularly undifferentiated dyspnea, is it cardiac or not, and obviously has some prognostic features as well. So we might have a separate talk on BNP and its utility. But it's 1:15, so we might just take time to thank Adel for his presentation. I'm sure you'll be happy to answer some more questions after the presentation.
Yeah.
Okay, thanks everyone for coming.
Thank you.